Thank you, Simeon. Thanks, everybody. It's such a pleasure to be here. I reached out to Simeon. I'm like, do you think maybe I could come back out? Because I was here about a year ago. He's like, sure. I was like, oh my gosh, it's so nice to see all of you. And thank you for your interest and your engagement and for your dedication to your families. So yes, I am a nurse scientist at the Oregon Alzheimer's Disease Research Center, and I'm funded by the National Institute on Aging and part of the NIH, and I'm still funded, thank heavens. The last couple of years, the NIA has been really interested in funding people, outside of those of us that work outside the Portland metro area, as well as supporting rural families. So I'm curious, are any of you from rural areas? Couple. Oh, terrific. Thank you. I'm so glad you're here. So just a little bit about me. Oh, also, oh, thank you. Oh, thank you. Perfect. So part of my job is outreach, and so I'm due at Prineville, so I have to leave at noon. No, noon. So I apologize if I just run out, but that's our phone number, so if you need to reach me, that's just leave a message if nobody answers.
Also, before I forget, I have her slides and I have business cards here.
Oh, fantastic.
If you'd like a coffee afterwards, come find me, get a business card, and I will email it to you.
Fantastic, thank you. Are you able to see the slides okay? Okay. Just a little bit about me. So I grew up in Red Bluff. Does anybody know where Red Bluff is? Excellent. So my sisters and I have a farm. We grow prunes and walnuts there. And I was lucky enough to have the support of the community to go to nursing school. And then I just kind of kept going. And that's how I ended up at the Oregon Alzheimer's Disease Research Center. Like the Bend area, Red Bluff can get pretty hot, and it's always during harvest when it's really hot. And one of the things I want to do is talk about a case study about a person who's hot. When I tell people I'm from Red Bluff, they always say, oh yeah, that's where my car broke down. So today I just want to go over, I know many of you know what dementia is, so we're not going to spend a lot of time there, but just to make sure we're all on the same page. And then we're going to talk about behavioral symptoms and research opportunities. I know many of you are experts, so I'm hoping this will be a little bit of a give and take. Hopefully I'll be able to wrap up in time so we can have not only questions and answers from you to me, but from me to you, so we can share in the experience. So many of you know that dementia is an umbrella term that describes a variety of diseases in which the cells in the brain die due to pathology related to amyloid, tau, Lewy body, and many times we kind of don't know why. But it causes difficulties not only with memory, but with judgment and function. You know that there are many different types, and the most common is Alzheimer's disease, but the most common in people under age 60 is frontotemporal dementia, which is characterized by difficult behavioral symptoms and in some cases language symptoms. So my team has studies on both of those. We have Stellar, which is a study for families who live with somebody with any kind of dementia. It's all online, and it's available to you if you're at all interested. And then we have a very special study for families living with frontotemporal dementia. So if you know of anybody, it's a pretty rare disease, but if you've heard of it, pass this on for us, please. This study is funded by the National Institute on Aging, and it's a national study. And again, it's all by telehealth, and people seem to really like it so far. Okay, and then knowing the types of dementia, it's not mandatory, but it can be helpful. So for example, if you have Lewy body dementia, we can, direct people towards medications that might help with some of those symptoms. If it's frontotemporal dementia, we can steer them away from some of the more common medications that aren't so great for that. But more importantly, when we know what type we're dealing with, we can help families understand what the course might be like. You know, every individual with dementia is an individual, and so we can't always predict, but sometimes we can help. Many of you know this. There are about 80,000 people in Oregon living with dementia, and about over 150,000 caregivers provide unpaid care. And this is data from 2024 alone, providing over 250 million hours of care, valued at over $5 billion in 2024 alone. So what you do is critical not only to your family, but to the state, and I thank you. When I gave this talk for the first time, they're like, no, that's an M. I'm like, no, it's a B, it's a B. Okay, so now let's talk about behavioral symptoms, and the first question, of course, is, well, what do you mean? What are behavioral symptoms? So we all have behaviors. So it's a little bit confusing, but behavioral symptoms occur both in the person with dementia and the care partner. And these are described as symptoms that are upsetting to anybody really in the family. And the problem is that in many ways, these are ways that we communicate. For some people with dementia, especially those with a frontal temporal type of dementia called primary progressive aphasia, we lose the ability to communicate, and so we communicate through behaviors. And sometimes those of us who can communicate also communicate through our behaviors. I'm sure none of you have ever been tired or hungry. Go to your spouse and say, well, why aren't you going to cook me dinner? I cook you dinner every single night, and you're not going to cook me dinner. That's a behavioral symptom, right? But these are some examples of what we might see in all of us, repeating the same question over and over, yelling, crying. For people who have memory trouble, they forget that they haven't brushed their teeth or forget they haven't taken a bath, and so they're like, I already did it, I don't need to, or they refuse to do it. So that's one of them. That's an example of a symptom. What causes them? A lot of times we just don't know. I mean, in our own selves, we can kind of be more reflective and think back, but oftentimes we can't really tell if it's a person living with dementia. So we think that an environment has something to do with it, pain, fear for all of us, communication. I mean, I can go on and on and on. But the other point is that dementia can cause symptoms because we know that many of the dementias, like Alzheimer's and Lewy body, kill the brain cells. And so we may have delusions that somebody's out to get us or hurt us or steal from us or has having an affair. That's because the brain cells just aren't working. Or the brain cells in the hippocampus may die and we just can't remember. So we have to ask the same question over and over. So that's the pathology related to the symptoms. So our team just finished up a study and we collected data from collected data from 188 caregivers, and we asked them when they started the study, what are the behavioral symptoms you want to work with and while you're in the study. And we had over 500 behavioral symptoms written down, and our team collated and categorized them into these categories. And I'm not going to go over each one, but know that they're varied and they're complicated, and they have and some are more distressing than others. Again, this is where we got the data. That was called the Telestella study. I don't know if any of you were at Telestella, but that's what similarly in Speller, that's what we're doing now. So if anybody's interested, let me know. So the symptoms they talked about were things like she keeps losing her Bible. He hides open cans of Pepsis all over the house. He throws the food on the floor for the dog. They talk behind my back. He wants kissy face every hour. She sneers at my food. She smokes in the closet. He wakes up punching. So these are very individual, right? It wouldn't occur to me, but what's important is they happen and they're upsetting. So really, any behavior that we do or a family member does that's upsetting is important and deserves to be addressed. what we found in our study is we taught people how to address the symptoms. And this is kind of rudimentary, but it's a graph that shows the burden level of our caregivers went down, and it was a significant lowering, which made us very happy, and we're hoping to continue the work. Some of the symptoms are more upsetting than others. So repetitive symptoms like asking the same question over and over may happen every day, all day, which is upsetting and exhausting, but it's really the agitation, anger, and aggression and wandering from home that are more upsetting, maybe not as frequent, but very upsetting. So I'd like to take us through a case study of George and Eden. So George has moderate Alzheimer's disease. He lives at home with Eden, and today he feels hot. He probably lives in Red Bluff. And he has a headache. And he sees the window with the air conditioner, he sees the door, so he walks over to the window and cools off. To cool off, his head hurts. So some of the things we know about George is we know he has Alzheimer's, so the disease process is there. The environment is making him uncomfortable. He's a kind of can-do kind of man. He if there's a problem, he'll fix it. He's hot, he's going to walk to the air conditioner. And his head hurts, he's in pain. So now let's bring in Eden, George's wife, who's exhausted. George has been up all night. He's has run away twice in the last week. She's worried about his safety. She feels trapped as a caregiver. She wishes someone would help her, and so she calls her daughter and cries on the phone. So with Eden, I mean, you can already tell me there's a lot of problems going on here that can lead to behavioral symptoms, right? Fatigue, disease, anxiety, depression, and then this sense of feeling trapped is a very real phenomenon. Over 60% of caregivers express this feeling like, I can't do anything else. This is what I have to do, and it makes people feel tired, frustrated, and burned out. And I think that's why organizations like Care Partners is so important, because we need to connect with each other and talk about these very real feelings, because even just talking about it can help reduce that sense. And there's probably other things that Oregon Care Partners can do that helps with getting services and support, like respite. Okay, so Eden sees George walk to the door, and she yells. Behavioral symptom. She yells, "Stop, George!" She runs over and touches him. He's kind of alarmed, and he swings out at Eden. She puts her arm around him to drive away from the window. He's frightened, and he pushes Eden away. Even though Eden is his wife of 48 years, he's startled and frightened and hot and has a headache. She's exhausted, anxious, and depressed. It's kind of a setup for all kinds of problems, right? So we have two tired people, both are anxious. George wants to feel better. Eden is worried. It's just a tough situation. So I have some suggestions to address these behaviors. I want to say out front, I'm not a magician. I don't have any magic theories. Behaviors are part of dementia, especially in progressive dementias like Alzheimer's and Lewy body. They're going to be more common, and there's not always a great answer, right? But we can try, and that's what we need to do. Do any of you remember this? Yeah? Have any of you got caught on fire and had to do that? I have yet to meet somebody who has. So I thought, well, I'm going to steal it because this is so important for us right now. So what I recommend is that when there's a behavior occurring that's upsetting to you, stop, drop, and roll. So first, this is what we teach the care partners in our studies. Watch, look, and listen, and see what's going on. What do you see? What can you hear? And it sounds a bit rudimentary, but sometimes just watching a person as they're engaging in the behavior can give us clues as to why it's happening And also, importantly, can give us clues as to what's the trigger so that in the future we can get in front of it. Drop. So here we have to take a deep breath and kind of, just for a minute, try to drop the fear, try to drop the anxiety. I think Eden's case is kind of classic. She's tired and scared, and so she's going to react. But maybe for just a second, she can take a deep breath, drop her shoulders, and relax for a minute so that she can think more clearly. And then roll with it. Go along with the behavior as much as you can. Of course, we have to keep our family members safe, but don't correct a person. I think all of you know this. You're all kind of experts, but I've met families who will feel a desperate need to correct them. For example, a person may look out today on July 16th and say, oh, Christmas is almost here. I have to start buying presents. And the family member will be like, oh, no, it's July. Yeah, you just have to roll with it. Oh, yeah, we should get presents, sure. Nobody cares, right? Just go with it if you can. So use the information from the stop, drop, and roll to make a plan. So again, as the disease worsens or progresses, there will be more behaviors. We know that behavioral symptoms of dementia occur along the whole disease trajectory until really the end of life, and even at the end of life. So in our Telestella study, we said only people who care for somebody in the moderate to severe stages of dementia can join our study. We didn't want the people in the mild phases because that's not where the behaviors are quite as common. And so we had, again, 188 people join our study, and of those 188, 21 of their family members died while they were in the study, meaning even at the severe stages, these families were dealing with really stressful behaviors. Behaviors happen in dementia. And so I suggest that we make 4 lists. So list 1, I'm sure you've all done this already, but make a list of friends and family that can help you. And this is somebody you can trust. Now, one thing I hear in my practice a lot is, my daughter's in town, but she has 2 small kids. I can't bother her. My son, he's so successful. I don't want him to have to worry about us. Well, the truth of the matter is that as adult children and as spouses, we want to know, we want to help. And in fact, the University of Pittsburgh had a study where they put a billboard saying, it's time to help your family member with dementia. It's important for a couple of reasons, not only because we want to help, but also what the research tells us is that when other family members help, it helps those people too. It builds a sense of altruism and meaningfulness in their lives. Yeah, they're busy, but I have some tips for that too. Part of the problem with being a caregiver is you have to train your team. You can't just call them up and say, hey, give me a hand. That doesn't work, right? You have to teach them how to care for you. So, get your kids, your religious community, your pickleball group, whomever. You need to tell them, yes, we want help. And I recommend training them early before the crisis happens. And what you do is this is list 1.1. Make a list of all the things that you want them to do to help you. So make us a casserole and deliver it to our doorstep. I'll put a cooler out there on Tuesday nights. Take George for a walk. Call me if you're at the grocery store, pick something up. I gave this talk yesterday, and they said that it would be really helpful if somebody in the family would give them gas money so they could drive to see their family member who lives far away. I'm like, brilliant, put it on your list. You can put anything, it's like your Christmas list. You can put anything you want on it. Santa Claus can always bring it, but why not, right? And the other one was, the other thing they said is, people come up to me and they ask me how my husband's doing. He lives in memory care, and they feel as though, because they've asked me about how he's doing, they feel like they've done enough. And what I really want them to do is visit him in memory care. So I said, put it on your list. Take 10, and you have to teach them. have to teach them how to get into memory care, how to sign in. You have to teach them that you may not have a full conversation, but just your presence is important. But when you put in the effort, they'll pay you back. And then also remember your family members who are distant, they don't live in the same town as you and your family member with dementia. So I was a long distance caregiver. My sister was the main caregiver for my dad. And I just asked her the other day, he died. And I said, you know, I don't think I was that much help. And she's like, oh my God, you were so, I'm like, really? But what happened was I would call her a lot and she would just vent. So I think I have a second for a story. He's a farmer, he was a farmer, and his life was his pickup truck. And we had to take the pickup truck away. Take his driver's license away. And my sister called me. She was really distressed. She's like, Dad got the pickup and he's driving around in town. And I said, well, you know, go ahead and call the police. And she's like, yeah, but I can't remember the driver's, you know, the license plate number. I'm like, Hillary, he's the only guy in Red Bluff with a Ram pickup that has a bumper sticker that says, retired, I'm just horsing around. I'm like, just call him up and see what happens. And so she did, and nothing happened. But, you know, just kind of being able to talk about it was important. And then she would ask me to come down and stay with him so she and her husband could take a vacation, that kind of thing. The other thing is that distance caregivers can do a lot. Like many of the families I work with, the long distance family member manages the finances or manages the medication refills. And even something as simple as mailing a postcard once a week could be really helpful because it's a nice distraction. Oh, sorry. Okay, so, here we are, distractions. Make a list of distractions. Distractions are really, you know, pleasant events that can really help us go a long way. And these are distractions both for the family member with dementia and for all of us who do the care. So this is another list of things that you might like or they might like that can get all of our minds out of the rut and go on to more healthy behaviors. Watch a movie, have a cold beer. You know, the non-alcoholic beers these days are so good, and why not, right? Go for a walk, go to church, play cards, just anything that you or your family member enjoys. I did work with one family who said, you know, my husband, he wants to watch Casablanca every single day. And I don't let him. I'm like, why not? I mean, if he's happy and you have, how long is Casablanca? Like 2 hours? I'm like, that's 2 hours for you. If he's happy, go for it. You know, anything that appeals to you and to your family member is great. Engage your services. You know, the Partners in Care can certainly help you with this, but the Alzheimer's Association has a 24-hour helpline that you can call just to get services, but you can also just call them if you're tired, frustrated, just need to talk to somebody. They're master's level prepared counselors and they can help. There's the Oregon Aging Disability Resource Connection that can help you identify services and supports. Senior Center, Partners in Care, there's all kinds of community groups. The one thing that I find interesting in my clinical care is people tend to walk away from the organizations that they were involved in. And I know that part of the problem is that friends and families get scared, they withdraw, they don't reach out to you as much. So it falls on you to do the reaching out. But go back to your club, your organization, your church, because these people do want to help. Again, they probably don't know how, so you might have to teach them, but they do want to help, and so definitely reach out. These are just a couple thoughts that I had. So the Oregon Lifeline provides funding for a phone bill. So, you know, $20, sure. The point here is that if you can find something that helps you that's not specifically related to caregiving, go for it. Anything that makes your life better is important. And then this is a wonderful program that provides access. So amplified speaker phones, cell phones. This is just one page. One of the things they provide is For some of our families who live with Parkinson's makes a person's voice really soft. And so there's all kinds of therapy you can do, but at some point the voice is so soft. This program provides amplifiers, so they just amplify the person's voice for them. So there's all kinds of great services and supports out there. What's the other one? The Aging and Disabilities Resource Connection. Again, they also provide information about respite, food services, you name it, they've got it. Okay, and then your clinical team. The other thing that surprises me in my work is that people will sit down with me and say, oh yeah, about 4 months ago, he got really combative, so he had to go to the emergency room. And I'm like, I'm their dementia clinician. I'm like, why didn't you call me? You know, what way? You know, I want to know this. I could have adjusted his medications. We could have talked on the phone. So make sure that your family member's clinician is involved. And we call it the dental model. We want to see our patients every 6 months. We want a relationship with them. We want to know how they're doing. And then also, if you're a caregiver, make sure you stay in touch with your clinician. There's a recent research study that found that many of us as clinicians don't ask, are you a caregiver? It just doesn't occur to us. But caregivers are, for folks with dementia, are at much higher risk for high blood pressure, infection, anxiety, depression, and even memory loss themselves. So it's really important that your primary care provider knows this and can help you monitor your health and well-being so that you don't get sick too. And let them know if you're struggling. That's important. It's kind of a strange world these days, but it's important to keep your team informed. And here's an example. So for example, if your family members really, having troubles with a lot of behaviors, make sure they're on the right medications. So many of our patients get Aricept, also known as donepezil. Memantine, also known as Namenda, is nice later in the disease process. Oftentimes we'll give our patients antidepressants, and sometimes if a person's delusional, we'll give them antipsychotics. So for example, I've had a couple of patients who the husband is the person with dementia and the wife is the care partner, and the husband with dementia is absolutely convinced his wife is having an affair. And you can't imagine how devastating it is. This woman has never had an affair in her life and is working so hard to keep him happy and being accused of having an affair. It's the disease. And antipsychotics can really help with that symptom, but they do have side effects, and so it's a very careful conversation. Make a plan for when the behavior happens. So in Eden's case, she needs to make a plan for when George starts to exit seek again. So she's like, okay, well, I'm just going to brainstorm. Here's some ideas. I'm going to put a slide lock on our door. I'm not sure if that's legal, but putting a slide lock or bells or something so that the person leaving the house, you have some kind of warning. The other one that can be really helpful are the child door handle things that you can't turn them quite as well. They rotate and you have to squeeze them to get out. The other one that's helpful is, have you ever gone to your favorite store and you're like, oh, I'm so excited, and you walk up the store and it has the sign that says, sorry, we're closed. Do you ever check the door to make sure they're closed? Oh, you do! I never do. I'm like, oh, they're closed, okay. And so put up a sign that says, sorry, we're closed. And people are like, okay, well, they're closed. And make an appointment with your person's doctor to discuss, and I'm gonna paint my nails. And I love that because we want Eden to take care of herself too. And she needs a manicure. And I love how she's thinking about herself too. So, and then she has a list of distractions. She's like, well, I'll offer him a non-alcoholic beer. I'll put on his favorite music. He loves golden retrievers. I'll put the book out for him. We'll look at the scrapbook. And in my mind, George is a farmer, and not every farmer loves to come home and have their family take their boots off. So why not? Can I take off your boots? Doesn't really matter if he's wearing boots or not. It's the idea of sitting down, putting your feet up. Okay, so take two. Eden's ready. So she sees George walking to the door. The door is locked, so she doesn't worry. Okay, he's not going to leave. So she stops and she watches. She takes a deep breath to drop her anxiety, and she's like, all right, I'm just gonna put his favorite music on my phone. So she puts on the music, she cranks up the volume, he turns around, he's still kind of upset, and so she's like, how about a cold beer? Yeah, sure, it's 9 o'clock in the morning, but who cares? And he follows her to the kitchen, and Eden rolls with this. She gives him a cold, non-alcoholic beer, he sits down, life is good for a couple of minutes, and she starts her manicure. Now, this is just a story, right? It's not always perfect, it doesn't always work. That's why you have your lists, so you can go back to your lists and try something else, because it doesn't always work. What works one day may not work the next. Always be prepared and always take care of yourself. So today we talked about dementia basics, we talked about behavioral symptoms, we went through a case study, talked about lists, and went back to the perfect case study where everything was great. And I'm going to just take some questions. Yes, I'll repeat your questions.
How do you cope with the surprise of a new behavior?
How do you cope with the surprise of a new behavior?
You just think you got it.
You got it.
And then
everything's great, and then something happens. Yeah, again, I think that if the person's safe, I think what we really learn is to watch. So in our study, we use the ABC plan. We tell people to look at the behavior. Helen Kales has another program called DICE that says describe the behavior. So if the person's safe, try to take a minute and try to figure out what's going on, and then you take care of yourself. Take a deep breath, roll with it if you can. If they're not safe, that's a different story, and that just requires some intervention. But there's lots of surprises out there. My dad was on hospice, and my sister says, Dad, do you want anything? And he's a type 1 diabetic, and he's walking around, he's like, yeah, I want a scotch and soda. And we're like, oh my God, you can't have a scotch and soda. And my sister's like, sure. And I'm like, okay, all right, well, let's roll with it. So she got him a scotch and soda, and he didn't drink it, and he was happy. It's like, if you can roll with it too. Yeah.
How do you work with someone who has lost all sense of smell and taste and doesn't want to eat?
How do you work with somebody who's lost all sense of smell and taste and just wants to eat?
Doesn't.
Oh my gosh. That's a hard one, and that's where I get my professionals involved. One of the things that I've noticed in my work is we don't really use our professionals as much as we could. So for example, somebody comes in and they say, my dad's falling all the time. Well, he needs to see a physical therapist. Well, he can't see the physical therapist because he's not going to remember anything, but you are. So in that case, I would arrange a meeting with a dietitian. And dietitians have all kinds of clever ideas. I don't know what they are because I'm not a dietitian, but they can talk about the caloric intake, how to sneak those calories in when possible, and just how to deal with these challenges that come when a person can't smell or taste. The other thing is make sure you talk to your doctor about it. Make sure, for example, they don't have chronic allergies that can easily be treated. But you also need to know that the centers in our brain that control our hunger are affected by Alzheimer's, Lewy body, vascular dementia. So sometimes that part of our brain is turned off, so we're just not hungry. Other times it's on and want to eat everything all the time. So issues around eating, appetite, I just go straight to a dietitian. Yeah.
Do you have any strategies when you're dealing with the caregiver who's resistant or denying their own growing new behaviors that indicate that they also now might be joining their husband in dementia, but right now they're considering themselves a very capable caregiver because the children were noticing perhaps not.
Yeah, so what do you do with a caregiver whose cognition probably isn't top-notch and they're resistant to support? And that's probably one of the most challenging situations because one of the symptoms of early dementia is what we call anosognosia, a lack of awareness. And I'd spell it for you, but I'd embarrass myself, so I'm not. But this anosognosia, this lack of awareness, I don't have a problem, I'm fine. No, he has a memory problem, I don't. And that lack of awareness is it's like one of the hardest things to deal with. So what I recommend is make the problem about you. So, this person probably needs an evaluation. So something along the lines of, I stay awake at night worrying about you, and it would just make me feel so much better if you and I could go talk to the doctor about your memory. Because I know you probably don't have a problem, but let's just check it out, do it for me. That doesn't always work. And sometimes, unfortunately, you kind of have to wait for a crisis to happen and be ready. So I work with a person who specializes in housing and helping us find homes for our family members with dementia. And she said, there's 3 places I can think of that would work for you if your family member, if you can't move right now, the next time the person's hospitalized, the easiest thing to do is go straight from the hospital to the facility. Now, I know that wasn't your question, but waiting for the crisis sometimes is the most uncomfortable. But I would definitely also talk to Bethany, because she might have some ideas about how to deal with that, because it's tricky. Because if somebody came up to me and said, Allison, I think you're having memory trouble, I'd be like, no, I'm giving you a talk. This is what I do. And the reality is, if I'm a person with early stage Alzheimer's, maybe I do, but I have no conception of it. And then you're going to tell me I can't drive. I can drive perfectly fine. So it's hard when you think about somebody coming up and telling you that, how that feels and what it feels like. So thank you for your concern. Yeah.
Strategies for dealing with your partner's sudden mean responses.
Sudden mean responses, lashing out.
Yeah.
Think about when it happens, if there's any pattern at all. So things like constipation, needing to pee, hunger, fatigue, and pain. So I've met with families who tell me things like, he used to have really bad low back pain. He used to take like ibuprofen like twice a day. He doesn't anymore. He never complains about it. Well, the reality is he can't complain about it because the Alzheimer's has robbed him of his ability to put it together that his back hurts, to find the right words to say his back hurts, to ask for the right medication, or to even go to the medicine closet and get it. So think about things like pain, constipation, urinary issues. Also think about times of day. So if this lashing out tends to occur later in the day when people are tired, sometimes an early afternoon short nap, a 30-minute nap, may be helpful. It could also be that we just don't know why a person lashes out. And that's when you kind of roll with it, try to distract, try to get something else going on. But it can be so hurtful because you're working so hard, and it can be just really, really frustrating. Yeah.
I have a friend in Portland who I don't see very often at all.
Yeah.
And I've had a little contact with her son. She's been diagnosed with dementia, but I noticed a couple of years ago that she was having problems communicating. Her memory seems okay,
Yeah.
but she can't carry on a conversation
Yeah.
any longer.
Yeah.
So
Yeah.
I don't know what that's all about. I guess I don't know much about dementia.
Yeah, so the problem is that her memory seems okay, but she can't really communicate very well. And that could be a special type of Alzheimer's called logopenic Alzheimer's, which affects the sides of the brain. brain. So a person, their memory may be okay, but the parts of the brain that controls our speech and our ability to communicate is affected. And so that's somebody that should probably see a dementia specialist. Yeah, yeah. Yeah.
So, my sister, I sort of attribute it to a hypochondriac, but I'm not sure that that's really what it is, and I want to take all of her complaints seriously.
Mm-hmm.
And so, she's had all kinds of exams and so forth, and nothing ever comes up that says, yeah, this is why you have pain here and why you feel like your brain is painful. And she has had all these tests, but it's like she is very focused on a certain thing, and I can't get her to change the subject. You know, she's like, she gets, she goes over the same rut, kind of tells me about her issues, and I can't seem to, and she feels like the doctors aren't helping her,
They don't
which
listen.
they're not, because
Yeah.
they're not finding something.
Yeah.
And she's got a million doctor's appointments, and it's like, and who's bringing her, you know? And,
Yeah, yeah,
and
you're
it's
doing
like,
all that work.
and I feel like I'm a hamster sometimes, just running around
Yeah.
the wheel.
So your sister has lots of complaints, but we can't really find an organic reason for the complaints, but she talks about them all the time. Is this a new problem?
Somewhat new, but also I can recall years ago that she would say, oh, this hurts or that
Yeah,
hurts.
yeah.
So I mean, it's not totally new, but now it's
Yeah, constant,
more
yeah.
constant. Not constant, but
But
she
more
brings it up a
noticeable.
lot.
And the thing of it is a person with Alzheimer's or other dementias is we bring our person with us. So it may be that, you know, she'd had these symptoms earlier, but now they're more and more. And if she's repeating the same stories over and over, it may be worthwhile to have her see a neurologist.
Well, she already does.
And then,
He's trying to rule out things.
good,
and-
okay.
But there hasn't been anything, the results have basically come in, and there's not anything that he has found.
Mhm. And so at this point, I would suggest a psychiatrist. It may be those ruminations, that obsession is really getting in the way of her quality of life. I don't know. But that, you know, there's, you know, a psychiatric nurse practitioner, a psychiatrist, somebody that can prescribe something after they assess them, of course. But that obsessiveness has a flavor of rumination, obsession that can actually be treated with medications. So I would, if she hasn't gone down that route, I would encourage her to do that. Probably not going to do it. There's so much
And take
stigma.
more medications when she doesn't want to, you know.
Yeah, it's a vicious, yeah, and then peeling off medications she doesn't need, you know, it's tricky. And then, you know, people don't give her the time and energy because they're exhausted. But if she could get with a good counselor and a good, maybe start with a counselor to talk about how nobody listens to her, and then hopefully that counselor can convince her to see a person to treat her. Yeah, go ahead.
So at the very beginning, you made the list of all the different dementias.
Yeah.
And is there a physical test that they figure out? Like, is it actually like a scan or blood test to figure out which type of dementia as opposed to just answering questions and
Yeah.
behaviors?
Yeah, kind of. We're doing better. So there is a blood test for Alzheimer's now. It's not perfect, but it's the way I think about it is a jigsaw puzzle, and it helps put the pieces of the jigsaw puzzle together. And what it does is it tells us, this is strange, it tells us how likely it is that that person will have a positive PET scan that shows Alzheimer's. So instead of having to go through a brain scan, they can do a blood test. And to me, it doesn't kind of make sense. When we get those blood tests back and they indicate that the person probably has Alzheimer's, we tell them, you know, we don't necessarily make them go through a PET scan unless they want to. But a PET scan also would show, is it Alzheimer's or not? An MRI will show us if it's vascular dementia. So vascular dementia occurs when the circulation to the brain is impaired, just like heart disease. Some parts of the heart aren't getting a full amount of blood and you have chest pain. Well, you don't have brain pain, so you can't really tell if there are parts of your brain that aren't getting enough blood. But an MRI shows us that. And so if somebody's having symptoms of dementia and we do a brain scan and we see those changes on the brain, we can say that's likely vascular. We also do what's called a DAT, D-A-T, DAT scan for for persons who seem to have Lewy body dementia. It's another type of brain scan, and I don't do a lot of that work, so I can't really explain it very well, but there are scans for that. But you're right, where we start is with a cognitive assessment. And then if we're confused by the assessment or we're not really sure what's going on, we'll have them see our neuropsychologist who will do a full, 1-2 hour battery and give us a better sense of what's going on. And that might be something that your person would do well with, would be a full neuropsychological evaluation.
The problem with those is that the anxiety that's caused by the
Yeah.
testing itself, that her brain just freezes.
Yeah.
And she can't answer any questions.
Right, right. And that is diagnostic in and of itself. And the neuropsychologist, who's also a psychologist, will be able to tell us, oh yeah, this person probably has these skills, but they were so anxious. The first thing I would do is treat the anxiety or something like that. I'm gonna have to go. One more question.
What's the name of the blood test?
Oh gosh, it's called AD Detect, AD-Detect, and it tests for amyloid and p-tau217. Woohoo! Does anybody here play bingo? Where are the bingo players? I have.
Give you my.
No, you guys have played bingo? Okay, well I've got some daubers for you. I'll leave them with you. So the first person that comes up and asks for more information gets a dauber. It has our email address on it, so if you have questions. I have information on our studies, and you can certainly take one of these cards, and our team, it doesn't matter if you take the FDD card, but you really want the Stellar card, it doesn't matter. We have a very close-knit team, and they all talk to each other, so we'll make sure you get to the right place. And I think that's all I have.
Yeah.
Thank you so much for your patience and interest.
Thanks.